Hey everybody, this is Dr. Ben Pearl, and this is our episode of Fitfoot U, and I am honored to have an old professor of mine, and actually he's a young
So
thought,
old is the operative word.
professor, so I don't want to age you, but he is, I always call him the John Madden of infectious disease and podiatry. I mean, instead of the telestrator, he's got his abstracts at the podium. Welcome, and such an honor to have you here tonight.
Thanks, Ben. Yeah, old is the operative word there. But I don't like him being compared to John Madden. Number one, he's dead, and no, number
Well,
two,
your enthusiasm,
he
your
was
enthusiasm.
always a really big guy. And I know, listen, I know I'm a big guy, but come on, you don't have to call me fat to my face.
That one.
That's just
All right.
rude, Ben. You
Let's
know,
let's let's move on to your expertise. You're excited about some new antibiotics, and I'm going to give you sort of carte blanche to sort of give, with focus to podiatry, some of the things that you're excited about with some of the new antibiotics that are out.
yeah, absolutely. Listen, let me give the first one, and that's omadacycline. And I will tell you, let me full disclosure, I am a speaker for Paratech Pharmaceuticals, but this is not being sponsored by Paratech. It has nothing to do with Paratech. And I will tell you that in the last 40 years of dealing with every new antibiotic that's come on the market, I've never seen an antibiotic that works as well as this. It's a tetracycline antibiotic. It's what they call third generation tetracycline. If you have the original tetracycline first generation, minocycline, doxycycline second, and now you have omadacycline, which is a third generation. And it's called that because it has some modifications on some binding sites that make it effective against organisms resistant to other tetracyclines. In particular, it is designed to be effective against MRSA. So it is an anti-MRSA tetracycline that also has expanded gram-negative activity, really good enterococcal activity, activity against other strep. It's just a really good drug. But what's neat about it is two things. Number one, it's once a day. So it's easy to take, 300 milligrams once a day after a loading dose, 450 milligrams once a day for 2 days. It's 300 milligrams once a day, PO. It is one of these drugs that we call bioequivalent. The PO is equal to the IV. So it doesn't matter whether you give the PO or the IV, the amount of antibiotics circulating in the system, the efficacy is going to be the same. So it's a bioequivalent drug. But on top of all of that, what's really neat about this is tetracyclines have inherent anti-inflammatory activity, and and that really knocks out cellulitis. And I've seen incredible cases before and after where just within 2 to 3 days the cellulitis is gone. It really is remarkable. Now, I mean, I got lots of pictures I could show you here. I work real closely with a wound nurse practitioner down in Phoenix. I'm in Sedona, Arizona now, and her name's Annika. And one of the best wound clinicians I've worked with in 40 years of doing this. And Annika, I turned Annika onto this. I do her ID consults for her, and she's been pumping it out like crazy. And the pictures, the results we're getting are just absolutely mind-blowingly good. So that's one drug. And again, I wish I could, if I just hold these up, it's not going to show much, but there's one in particular, if I can show it. I mean, I'd have to dig it out. It's an arm, and now I'm not going to take credit for working on the arm because that, of course, would be out of scope of practice. But this is how the arm started. All right, you can see major cellulitis. After a week, cellulitis is pretty much gone in the wound. But ready for this? This is after a month.
Nice.
I mean, it's crazy. It's crazy good. So it's a very, very good, very effective antibiotic, and it's probably the one drug I'm most excited about after all these years. Now, other than that, we've got other drugs. Also in the MRSA field, we've got the lipoglycopeptides. Now, they're not as new as this. They've been around for about 10 years or so. The two in particular are dalbavancin and iridovancin. And what's cool about these drugs is they're a single IV infusion. So the omadacycline's PO, the dalbavancin and iridovancin are infusions, but they're a single infusion. And in their clinical trials, a single infusion was found to be as effective as 7 to 10 days of twice-a-day vancomycin in the hospital. And on top of that, not only are they really good for skin structure infections, there are also some really good data for osteomyelitis, in particular with dalbavancin. It's off-label, but 2 or 3 of these single infusions, 2 or 3 of these back-to-back, like 1 week apart infusions of dalbavancin have been shown to be very effective for osteomyelitis. And iritavancin, the data is not as convincing, but it's getting there. So, I mean, we've got some new stuff that really, really are highly effective antibiotics that we can use for skin and skin structure. We need to get away from vancomycin. I talk about how vancomycin is 67, 68 years old now. It's about it's my age. But, you know, vancomycin, unlike me, should be sitting at home collecting Social Security and not being used on our patients. It's a terrible antibiotic. And then, God forbid, your IDs used a combination of vancomycin and piperacillin tazobactam, you know, the vancomycin combination. All you're doing is putting your patient into acute kidney injury. There's something like 150 papers now that have been published in the world literature looking at synergistic nephrotoxicity of using vancomycin, piperacillin, tazobactam. So we've got to get away from these old antibiotics we're using. We've got some new antibiotics. We've got some really cool work that's being done. We've got alternative therapies for osteomyelitis, some really beautiful data that's out there on oral therapy, a paper that was published about 3 years ago by, his name will, oh my God, I can't, but Brad Spellberg, Chief Medical Officer at USC Keck in Los Angeles, published a paper in the, I think the American Journal of Medicine, which was oral is the new IV. And he looked at the evidence for oral antibiotics versus IV for both osteomyelitis and bacteremia, and found there's not a single paper to show that IVs are more effective than orals for the treatment of osteomyelitis or bacteremia. So you really want to blow out your ID person's mind, tell them you want to treat bacteremia with PO antibiotics. Fact is, evidence supports it. So we have lots of cool stuff that's happened in the ID field, in the areas of osteomyelitis, in the areas of new antibiotics. It's really exciting. So I think, you know, keep your eyes open, keep your ears open, and next time your ID wants to use Pip, Tazo, and Vanco, tell them that you're wrong, you're not up to date, and you're going to kill your patient. So that'll get you in good stead.
I wanted to just piggyback on what you said, and this is a case that I have that is, and I feel comfortable showing this case because it is all but resolved. And this was a woman that had, and she's a teacher, and she had an unexplained ascending cellulitis in the ankle and a lot of stiffness, and the leg was just enormous. So the whole leg was swollen up. She did not mount a fever. Her white count was high when I got the blood work. I started her first thing on Keflex, but wanted to see her on a Friday before the weekend to make sure that the 2 to 3 days didn't warrant any hospital admission or, you know, other drug selection. And she wasn't thriving on the Keflex. So at that point, I did change her to omadacycline, and it has just in 7 days really been a huge turnaround for this particular case. Now I was fortunate in that I was able to get a tap on the joint, and it was turbid. And that's the next thing I'm going to talk about aspirates, and there's a lot you can say about that. But we got a quick gram stain, and then they identified beta hemolytic strep. Right. So one could argue after the fact, you know, should I have used Augmentin? And that's another thing that, you know, versus omadacycline. But at the time, you don't know what the bug is. And I was concerned about MRSA as well. And maybe you can speak to Augmentin's role. In this case, I had, because she wasn't a diabetic, I had started Keflex and not Augmentin. But maybe speak to some of the things. And I had another case of another gentleman that was on Augmentin with a plantar ulceration, and maybe you can speak to first the resistance patterns that you're seeing with drugs like Keflex and Augmentin, and if we don't have an isolate yet, when to pull the I guess the newer gun.
Yeah. I think they're really great questions. Now, just a couple of things. It's interesting you show that case that you use the omadacycline on, because as I mentioned, I speak for them. And when I go and give a lecture, of course, nowadays when you give a what's called a promotional lecture, you have to use the company's slide deck because it's been a vetted slide deck. It's gone through governmental regulatory control. And I'll always ask, and when I talk about how well this drug works and how quickly it works, I say, anybody else here in the audience have any experience using this drug? And most of the time, nowadays especially, because the drug's been promoted in our profession for about a year and a half, 2 years now, people like yourself will say, oh yeah, I'm using it. And I'll say, well, how are you finding it works? Say, it works great. And I can always say, you see, and I have to admit when I'm lecturing, I'm getting paid, but I say, they're not getting paid to say that. And you can see that's a testimonial. I admit I have to disclose I'm getting an honorarium to give a lecture. They don't. So that really is just a powerful thing when people like yourself who are not being paid, you just have had the personal experience. Now, Augmentin, I don't like Augmentin. I don't use Augmentin anymore. Way back when, it's amazing to me. I used to get 30 years ago, 25 years ago, I gave a lecture called the 6 antibiotics you could treat every lower extremity infection. And to this day, people who are like my age roughly come up to me and say, Warren, I still have notes from your 6 antibiotic lecture. I haven't given it in 25 years. That's before MRSA was an issue, and Augmentin was one of those. When I stopped liking Augmentin? When I personally had to take Augmentin. Have you ever taken it, Ben?
Yes, yes, it does do some GI stuff on you for sure.
Yeah, yeah. I mean, the pill's this big, and you have to take it with a full glass of water. And yeah, I would take it, and I felt like my GI, my stomach was going to jump out of the lining, of the abdomen. It's nuts, uncomfortable to take. I don't want to submit patients to that if I don't have to. So I stopped using Augmentin, and it's just too difficult to take. It's got good spectrum, it's got the anti-anaerobic spectrum because it is a beta-lactamase inhibitor compound. It has some advantage with gram negatives over cephalexin. It's got the enterococcal coverage, which cephalexin, Keflex does not have. But I can't justify using it anymore from an adverse event profile. So I don't really use it anymore. And I used to talk about using that like amoxiclav along with one of the quinolones like levofloxacin. I'm off quinolones. And you and I have discussed this. We know that quinolones, the number 2 cause of C. diff, potentiate resistance by MRSA, potentiate gram-negative resistance. More quinolones have been pulled from the market than all other antibiotics combined. There is no reason for a podiatrist to ever use a quinolone unless they have a documented gram-negative infection that is shown to be susceptible. We were talking about one of the gram negatives, and you asked me how to cover it. And I said, well, you have IV. There are a number of IVs that can be used, or there's one oral, and that oral happens to be a quinolone, levofloxacin, for instance. So in those cases, yes, it's an appropriate drug to use. But I don't like it. I don't like amoxiclav. I don't like quinolones anymore. As for resistance, MRSA is not the big deal that it once was. Rates of MRSA worldwide have come down. In fact, some really good papers lately in the diabetic foot literature, Larry Lavery's published in this field and a couple of others, have now shown that MRSA accounts for less than 10% of all diabetic foot infections. But that's also very regional, and it's also very local. Where you are in Virginia and your practice, you might have a lot of MRSA. We don't see as much of it. I do see some MRSA down in the valley, the Phoenix area, with the cases that I get sent. So we do have some MRSA here, but it's not. I remember into the early 2000s, every infection that came in the door had MRSA. We're not seeing that as much anymore. But you don't need to have a confirmed MRSA to use an anti-MRSA drug like an omadacycline. I mean, because it is so effective, you can use it even if you don't have confirmed MRSA. But I would start it empirically and see how the patient does. But you can de-escalate. In ID, we talk about the antimicrobial stewardship. We talk about the role of de-escalation therapy, where you start broad spectrum and go narrow. So, if you want to start, if you have a lot of MRSA in your area, you are concerned about MRSA, or, you do want to get a big hit, and you want to use like an omadacycline to start with, or even go ahead and use your amoxicillin clavulanic acid, that's fine. But if the culture comes back and it's just MSSA, then sure, you could probably switch over to a cephalexin in those cases. That you de-escalate, you narrow down the spectrum, because the whole idea of antimicrobial stewardship is to prevent resistance, try to decrease rates of antimicrobial resistance, which we all know is a big problem. And one of the reasons I really dislike quinolone so much.
I know every scenario is specific, but let's say you get a culture of something that might be a colonizer or not a primary pathogen. In general, and we're talking very general, let's say the patient is a diabetic, but they're not febrile, they're not being hospitalized currently. How long are you generally comfortable with seeing how, let's say, one of the new, like omadacycline, playing that out? And again, every scenario is specific in terms of whether to add something like a Cipro.
Right.
But do you have like maybe you could give people in terms of what to expect from a drug to do its job in terms of clearing out the cellulitis of a multi-pathogen potential infection?
Well, I think in 2 days you're going to know. In fact, the FDA, under what's called the ABSI guidance, acute bacterial skin structure infection guidance, their primary endpoint is at 48 to 72 hours, you have a 20% decrease in the area of cellulitis. So that's how a new drug gets approved. In 2024, a new antibiotic will get approved for skin and skin structure infections if in 48, 2 to 3 days, the cellulitis is resolved 20%. So, if that's good enough for the FDA, that's good enough, I think, for anybody. You can look at that and you're seeing the patient back, and don't wait a week to see these patients back. Don't wait 2 weeks. I reviewed cases where the podiatrist says, oh, cellulitis, infected ulcer, pus draining out of it. Patient to return in 2 weeks. No, patient comes back in 3 days. 3 days, you see the patient back. You look at how the patient's reacting. You treat the patient. I taught this back when you were in school. That's how long ago I've been treating this. You treat the patient, not the paper. All right. You treat the patient, not the culture result. So, if you grow a gram-negative, you grow Pseudomonas. Pseudomonas is the classic organism that is a colonizer. Pseudomonas has been found to be the pathogen less than 10% of the time. You're looking at 5 to 6% of the time. Pseudomonas is found, not even pathogenic, is found. So, you get this panel with a lot of different organisms. You don't know what's pathogenic, what's not, but it takes a couple of days to get that. Even with molecular testing, which I'm not a fan of in wounds, you'll start the patient on an antibiotic. It might be 2 or 3 days before you get the culture back or the PCR test back, and you now have this slew of organisms. But you gave an antibiotic that is only not that broad spectrum, but the patient's doing well. You keep them on it. You don't need to change the antibiotic. You treat the patient, not the infection. And you treat the patient, not the culture. And I really do think that, like I said, the FDA causes early clinical response. And if the endpoint of early clinical response is good enough for the new antibiotics, then I think that's a good cutoff point for you to determine whether or not your antibiotic's working, whether you need to make changes in it or not.
Just a moment to comment on the PCR train. You had some sidebar comments that we talked about before this presentation tonight, but talk about cost value if you see a role, a very narrow role.
Yeah, and I'll piss people off with this. Let me say where I do see it works. Fungus, onychomycosis. Now, as a disclosure, I do work a little bit. I haven't done a lot, but I do work a little bit with Baco Diagnostics, and they do PCR testing. But I give them credit because they're only doing it for toenails. They're not doing it for wounds because they don't believe that it has a benefit in wounds. Neither do I. But we're looking at, Aditya Gupta in the onychomycosis world has published over 800 papers. Wayne Bakotic, who is the medical director of Bacco Diagnostics, they published a paper about 2 months ago now that had 99,000 toenail specimens. I mean, that's mind-blowingly high, 99,000 specimens. And we do know that it does play a role. We do know that we have increasing terbinafine resistance. They can look for genetic markers of terbinafine resistance. So I do think in fungus, no question, we're at the point now that the evidence is really, really good. I have a whole lecture on this on diagnostic testing for onychomycosis. Osteomyelitis. I think it plays a role with osteomyelitis. I recently did a webinar with Alan Block and Jason, I'm blanking on his last name. We did for a company called Bone Support, which has a gentamicin impregnated hydroxyapatite calcium sulfite that is a flowable that you can inject locally into a bone, which has really good data for osteomyelitis. And we were talking about this, and Alan's a big believer in PCR testing, and he does all this PCR testing for osteomyelitis. And I said, I agree with you. I think for osteo, where you have a low prevalence, a low number of bacteria, and you have the sensitivity of a molecular test, and you also only are going to have 1 or 2 organisms. It's a really good way to go. Where I have a problem is wounds. Because if you send a specimen to a wound to one of these labs, especially if they're doing deep dive metagenomics, you're going to get 100 organisms. Because they're going to be every strand of DNA from every organism known to man, and some that aren't even known to man. Or RNA, what are you going to do with that information? How do you know what's pathogenic or not pathogenic? How do you know what to treat? It's not telling you that a particular organism antibiotic's going to work. It's telling you that it might have a resistance gene, it might have a MEK-A gene. You guys know what a MEK-A gene is? It confers methicillin resistance in most cases. It might have a VAN-A gene. They give you the genetic determinants of resistance. They don't directly run a test. That's issue number 1 I've got, is that I think it's extremely sensitive, but we don't know what to do with that data that we get. Number 2, cost. These labs are being reimbursed $1,500, $2,000, $3,000 for one of these tests. It's about $40 to $50 to do a standard culture. All right, $40 to $50 to do a standard culture. Can you justify all that extra money for one of these tests? So what's happening now in our profession is there are companies coming to podiatrists and saying, set up a lab in your office. And you look at all the money you'll make. In fact, I got a blast email that I'm sure a lot of the audience got also just last week from some company, I'm not going to mention names, that say, set up a PCR lab in your office. The benefits are endless. And what's the first benefit they list? Increased practice revenue. Ladies and gentlemen, if somebody comes to you and the first words out of their mouth are increased practice revenue, turn and run. Do not walk. When a skin substitute company comes to you and says, as they did to us here in Arizona, they came to talk to us. Oh, there's a doc in Phoenix who made $30,000 or $300,000 last year using this product. Run, don't walk away. I said to that rep, do you realize that the former CEO of your company is in federal jail because of selling like this? A buddy of mine just got an email yesterday about one of these skin equivalents that showed that a 4x6 reimbursement using their Q code for a 4x6 patch was $35,000.
Oh my word.
$35,000. That was reimbursement. And let me tell you, folks, you think you're going to make a quick buck? You're not, because you may, but you're going to pay it all back because the OIG and the DOJ are on top of this. It is on their radar. Why do you think the LCD just came out? The local coverage determinations just came out on skin equivalents, limiting the number of skin equivalents you can use. The fraud and abuse is mind-blowing because it's been sold as a profit center. And my concern is the PCR test. I will tell you that the Department of Justice has PCR testing on their radar. So just be aware. All I'm saying, you want to do it, be my guest. Just be aware that you're running a huge risk that this is going to come crashing down and you're going to be stuck in this middle of this, and they're going to come after you for a couple of $1 million.
Also on that vein, I know that some of the labs, and this is just more of a minutia point, but some of the labs try to control cost to some degree by only doing a few pods for like the fungus. How much does that actually reduce the cost from
It
that?
does, it does reduce it some. I mean, all I know is what I've seen sent to me
Sure.
in terms of what these labs have gotten in terms of reimbursement, and we're literally talking thousands of dollars. There was one lab that I was sent some data from that on every toenail was running a Bartonella panel. Bartonella causes cat scratch disease. Okay. And I said, well, maybe there's something I'm missing. I mean, in all my years and all my publishing in onychomycosis, I've never heard of Bartonella causing fungal toenails. It's a bacteria, but maybe there have been some reports. No, not only does it cause cat scratch, but it also causes some fever in the deep Andes of South America. They're like the only diseases caused by Bartonella. But this lab was running Bartonella on every toenail that they got coming into them. So yes, they can run specific panels, all right, looking for specific organisms. But here's a situation that they may miss what you need to get. I reviewed one case where a podiatrist was forced, he was in one of these big super groups that have these PCR labs, was forced to send his specimen to a PCR lab. It found gram-positive cocci. It was staph species with a MEK-A gene, all right? So he figured that out and he decided to treat for MRSA. And 3 days later, the patient's in the hospital septic. When the patient's in the hospital, they do a standard culture and they found a gram-negative rod that would have grown from a standard culture, but was not in the panel that this lab used for their wound panel. So yeah, they may control cost, but then you may miss something that could be a true pathogen. Patient ended up septic and bacteremic with a gram-negative that was not found in the panel, which would have been found with a stupid freaking $40 culture. Just do your culture. Going back to omadacycline, all right? In their clinical trials, they ran against linezolid. In their clinical trials, and just like every other clinical trial, they just use standard culturing to determine whether patients could be enrolled or not. And if you look at their success rates, their end of therapy, so that's like 7 to 10, 14 days after end of therapy, their late clinical response thing was almost over 90%. And in their diabetic foot population, which granted was small, they had a 98% success rate in diabetic foot infections using standard culturing technique to determine who's in the study. What more are you going to get? These labs are selling you this scared thing. You know, it's like, oh, you might miss something. Well, yeah, but the lab might miss something. So please, all I'm saying is there's a place for molecular testing. Fungus, possibly osteo, and maybe eventually skin and skin structure infection. But we don't, I use the example of the original cast of Saturday Night Live. They used to be called the Not Ready for Primetime Players. Here's my concern. We have all this data coming back to you when you send a specimen. What do you do with it? And no one has been able to define that yet. This is my opinion. I don't want people, people get mad at me, but this is strictly my opinion based on what I have seen and what I have gathered from the literature. So I'm putting that disclaimer out there also. All right, I'm entitled to my opinion, just like everyone's entitled to theirs. You might have some people out there saying it's the best thing since sliced bread. God bless you. If it's helping you, helping your practice, fantastic. Just my opinion, I don't see it yet.
Let's go back to aspirates a minute. I was fortunate in that particular case I showed to get a turbid tap. I just used a half cc of lidocaine, then went in with a bigger bore needle right into the ankle. What are some of the things that you think can increase your yield on joint taps, maybe small joints, a little bit more difficult? Any other caveats or things that that you can share that regarding the testing with joint aspirates?
Well, unfortunately, most of the joints we deal with are really small. So, I mean, you were fortunate you had an ankle. You can get a needle into a fairly large bore needle into an ankle. You're not going to get that into an MTP joint. Maybe the first MTP joint you'd be able to get something. But I've not been in the case of an ankle where the alternative is opening up the ankle. I think it's a great idea, Ben. I think what you did was absolutely 100% correct. You look at it, you mentioned the turbidity of it, which is great. You look for the gram stain, you look for the culture of it. You can look at the glucose in infected joint taps tends to be low. So there are synovial fluid tests you can do that can help you rule in, rule out infection. The problem is in the foot. If we're looking at knees, hips, ankles, whatever, that's one thing. In the foot, other than the ankle, I don't know that there's a lot of advantage of doing an aspirate other than maybe the first MTP joint versus just opening it up. I trained in surgery for 2 years, but I've never been a surgeon. I've always been on the ID side, but I still am a firm believer in INDs and surgery and, getting in. And as my mentor in infectious diseases used to teach, the best antibiotic known to man, surgical drainage. There's no known resistance to it. So get in, open it up. I still cringe a little bit. I see nowadays one of the newer, not really new, but one of the philosophies nowadays is after you do an IND, people mostly close it. And that always makes me clench a little bit because we always were taught, and even back in the days when you were teaching, I'm sure, or you were taught, I'm sure it was always you keep it open. But now there's more.
Well, I got a quick story. During my externship at Liberty Hospital, I ended up developing an acute appendix. And I went back, they thought it was a UTI. It hadn't localized to the right lower quadrant yet. And I went back to my primary care. He put me on Cipro, I think, at the time. And then it started localizing, and I started getting a kind of a green cast to me, and I was sent home again. And this time a general surgeon saw me. Well, I ended up back in clinic at Temple with an open wound and packed. And Scott Millay was nice enough to help me change the dressing because it was good. I'm in clinic and it's still draining a little bit. And at any rate, yeah, that to your point, everything was classically at that time
open and packed.
Open.
Yeah, nowadays, okay, listen, if it's working for you, good. I just, like I said, clench up a little bit when I see it.
I'm going to throw you a little curveball, and it's not a big curveball because I know you know a lot about this topic. However, there's going to be a gazillion different theories. But what do you think in this post-COVID world that we're living in on the so-called, I've been exposed to COVID, I'm now more susceptible, perhaps. Chronic fatigue syndrome has been something that's now been talked about in Congress with different viruses. Of course, a lot of theories. What's your thought process with COVID and how that impacts on soft tissue infections and the things we see?
Oh, I don't know that it has any impact on soft tissue infections. Certainly systemic issues, sequela of it. Long COVID. I have a colleague out here who developed long COVID, and he is still now 2 years later still unable to work. So there are definite systemic sequelae to that condition, to that virus. As for affecting soft tissue infections, it doesn't make you more susceptible to soft tissue infections. No, I don't find that at all. I'm wondering, I actually did a little searching for myself because after avoiding it for the first 2 years because we were crazy about masking and isolating and all, and I've had every vaccine after having 6 vaccines and always being good. I had COVID 3 times, and at least they've all been mild. They've all been like really bad colds. The first time I took Paxlovid, and within 24 hours, my symptoms were gone. It was really amazingly fast. Even though some questions that have come up lately about the effectiveness of Paxlovid in decreasing symptomatology. But it worked for me. Very difficult drug to take. Talking about Augmentin with side effects, it was a very difficult drug to take. But what I have found very interesting is that I used to get a cold maybe once a year or once every 2 years. I could go 2 years without getting a cold. Now I seem to be getting colds like every 3 months. And it's really strange. And I don't know why that is. And I've Googled that. I've done PubMed searches on this, and I've looked to see if previous history of COVID predisposes to other respiratory infections. And I couldn't find anything. I didn't really find anything to that. But it could just be as I'm getting older, my immune system's not what it used to be. But I just got over a cold last week. I mean, again, I never got colds. And it's really, really crazy. So I do think there's a lot we still don't know. I still think I don't see any effect in predisposition to skin structure. I will tell you that we predicted as before the world pandemic started and the WHO shut down things. Lee Rogers, myself, David Armstrong, and Larry Lavery published a paper called All Feet on Deck. And we talked about the potential risk to diabetic foot patients because of COVID. And that was primarily looking at shutting down of hospital wound centers, patients refusing to go to the hospital, patients not getting the care they got. And we postulated that the amputation rate was going to increase. Well, that's been an incredibly gratifying paper in terms of academia because we've been cited so many times, but it's been shown to be true. I mean, it's from around the world. Literature has come out now showing that during the height of the pandemic, rates of amputation in our diabetic patients skyrocketed. So we predicted it. Unfortunately, we were right. Again, good from an academic standpoint, not good from our patient standpoint.
Speaking of unsolved mysteries, what would your explanation to a patient be who, like, let's say that example I had of the cellulitic leg and ankle, where there is no known insect bite, no open wound. This patient didn't have even a previous history of venous insufficiency, which, as we know, can develop into a cellulitic leg. Where do these things? How do these things seep? What's the best way to describe that or explain that to a patient?
They really are. I mean, it really is a mystery. Now, in your case, you mentioned it was a beta hemolytic strep, which gets me thinking that the probable source of it was oral. The patient probably developed a bacteremia, whether it be a transient
She did
bacteremia.
mention some respiratory type things.
Yeah. So it could have been a URI, an upper respiratory source. It could have been an oral source. We know that, when you floss your teeth, when you eat pretzels, when you eat anything, you cause transient bacteremias. And in the mouth, in the human mouth, you primarily have strep. So it's possible that the patient developed transient bacteremia, got strep, and because of something in that ankle, be it previous trauma, something making the blood flow a little more sluggish, it just seeded. We don't always have answers. We don't always have answers about why patients develop osteomyelitis, for instance. Especially
sometimes dental manipulation and even dental cleaning can cause bacteremia.
Absolutely, but there's no recommendations for prophylaxis.
But watch out, if the patient develops a fever, they might die in a few days. I've seen it happen.
Yeah. Yeah, it's absolutely possible. But even, like I said, even with prosthetic joints, I'm doing the Piper Risk Management Program this year. We've done it 3 times. We're doing it next week at the Western Podiatry Congress. And it's myself, Luke Ciccinelli, who's now Chief Medical Officer at Pike, and an attorney, Neil Kornfeld. And we present a couple of cases. And one of them, the patient had a history of a prosthetic joint. So just to refresh my memory for doing this, I went back and I searched all the literature and I was looking at guidelines. So the American Dental Association, American Academy of Orthopedic Surgery, the guidelines for dental procedures in a patient with a prosthetic joint, they've gotten away from recommending antibiotics. So it certainly can happen with even routine cleaning. Bacteremias can happen. They can seed areas, but the recommendations for antibiotic prophylaxis aren't there, not at this point.
With my,
What are your favorite tests? We talked a little bit about this, but I want you to tell the audience and our viewers on this podcast what you think the best imaging sequences are for determining extent of possible osteomyelitis.
MRI with gadolinium. I mean, it's still, I think it's still been shown to be the best. See, FDG PET scanning. There's some really, really good data on PET scanning, but the problem is it tends not to be covered by insurance for osteomyelitis. It's still primarily used for cancer, but there is some good stuff with that. Straight CT scan can be useful, but I think most of the literature that's out there still stands on the MRI with contrast as being the best imaging diagnostic technique for osteo.
How much do you think you miss if you just do a straight MR?
Without the GAD, probably not that much. Probably not that much. But the problem is you can get the inflammation of the bone, the inflammation of the marrow, and it's not necessarily infectious. I don't know if you're missing all that much, because I know some people are concerned about using gadolinium, but it's still MRI in any of its flavors is still probably around the best, probably one of the best ways to go.
Okay, and then so we've covered imaging and any other things that you think are new and exciting. And
you told me we were going to go 30 minutes. We're already at 45.
okay, well then
We haven't even
we're in
had
the
a
home
chance to open
stretch.
up for questions.
Yes.
Okay,
Any
go ahead. What were
questions
you
in
going
the
to ask?
audience?
What were you going to ask?
Oh, anything else that you think is, and one tangent I thought of is any new mimickers. And we had Lyme disease. We had well, not that that's a mimic, that is an infection in and of itself, but we had gout, pseudo gout. Any other things that you think you're seeing more of as imitators or infections that we might not think of when we think of the standard bacterial infections that we should be aware of?
No,
that you're seeing on the rise?
I don't really see. I mean, if you're talking about, you mentioned Lyme disease, the tick-borne infections. Well, we don't just have Lyme disease now. We have ehrlichiosis and babesiosis, and there are all sorts of these, tick-borne diseases now. So everything that's tick is not Lyme disease. Fortunately, I haven't seen a lot of Lyme disease in my career. I've seen some, but not a lot. Out here, heaven forbid, out here, we have our haboobs, the dust storms. We don't have them up in Sedona, but down in the valley, down in the Phoenix area. And God, when I just cringed the thought of all that dust being kicked up, because then you've got coccidiomycosis. And, you've got all sorts of weird stuff out there. Listen, there's always going to be new emerging organisms. The biggest thing, I think the biggest concerns I have now are the development of a multi-drug resistance. I mentioned MRSA is not as much of an issue as it used to be, but now we're looking at terbinafine resistance. I touched on that for so you've got dermatophytes that are resistant to terbinafine. Inherently, you've got some new strains. There's the Trichophyton indotineae, which came originally out of India, which has now been shown to be multi-drug resistant and is spreading quickly. The first reported case ever of a Trichophyton metagrophytes type 4, I think it is, sexually transmitted disease in men who have sex with other men was just reported out of New York last week. So you now have fungal infections that are even being passed sexually. So you've got multi-drug resistant fungus out there. You've got Candida auris, which is an organism that not only is resistant to all known antifungals, it is also resistant to all known disinfectants. It's about 100% fatal if you've got a Candida auris bacteremia, and then the hospital room can't be used after the patient passes because they can't disinfect it. You've got the multi-drug resistant gram negatives. We've all been concerned with the MRSA, but the ESBLs, the extended spectrum beta lactamase, the other the carbapenemase resistant. They keep changing the names of them now. These multi-drug resistant Enterobacterales. We used to call them Enterobacteriaceae. So you've got gram-negative rods now that are resistant to all known antibiotics. That's the scary stuff to me. Fortunately, still relatively rare in skin and skin structure, still relatively rare in the foot, fatal in bacteremia, but it's going to come. It's there. We're still overusing antibiotics, both in humans and in feed. So I think that there is just a lot of concern I've got for the development of multi-drug resistant bacteria and fungi and yeast that is just going to continue to grow. So, I mean, heck, listen, you watch the national news, you're ready to kill yourself anyway, with what's in the world. So I'll just add this too. Now the organisms, you talked about COVID, if it's not a virus, it's a fungus or a yeast that's going to get us.
Any other questions out there for Dr. Joseph before we close out the evening? Okay, well, listen, I really appreciate you did a thorough job here. Are we going to see you at National this year in DC?
Yeah, I'll be there. I'm still editor of the Journal of the American Podiatric Medical Association, so I will be there. I'm not speaking. I think this is the first time in recent memory that I can think of that I'm actually not speaking at the APMA. But I will be at the APMA. I just did my registration and I have to get my hotel room now. And I'll be at the Western Congress, like I said, next week for the PICA talk. So we'll be around there. And so I'm around. I'm not hiding, even though I'm kind of in the middle of Arizona. I'm not hiding anywhere.
Are you going to get there are you going to get there right for the start?
For the APMA?
Yeah.
I haven't decided yet. I think it starts on Thursday.
Yeah.
Yeah. I'm thinking I might come down Wednesday night so that I'll be there
Okay.
Thursday.
Well, there will be some programming there, and we'll be sure to get you an invite to that on Thursday night. I know there's something going on, and hopefully we'll get some other alums from the school.
All right, sounds good. I look forward to seeing you guys.
All right, thank you so much.
My pleasure.
Good night. Good night, everybody.